that uveitis is a leading cause of visual impairment and even blindness. We know that uveitis can be infectious and non-infectious, which is very important because before we start immunosuppressive therapy in a patient with uveitis, we have to know which type of virus we're dealing with. Because if you treat a patient with infectious uveitis like toxo, with only immunosuppressive therapy, you will induce disaster. If you treat a patient with tuberculous uveitis with only suppressive therapy, you will end with disaster. So you can use immunosuppressive therapy in patients with non-infectious uveitis or under proper coverage with antimicrobial agents in patients with infectious uveitis. Like TB, we add anti-TB treatment with immunosuppressive treatment. Toxo, anti-toxo medication with immunosuppressive treatment. Syphilitic uveitis, anti-syphilitic treatment and immunosuppressive treatment. So you have, before you start such a treatment, it can be very dangerous treatment if you are not careful. Before we start such a treatment, we have to know which category of uveitis we are dealing with, infectious or non-infectious. In the past, it was always said that corticosteroids are the main line of treatment. This is not true anymore nowadays. Yes, it's an important line of treatment. However, we have now biologics. In the acute stage of uveitis, you need to suppress the inflammation as soon as possible. And the steroids are very effective for this purpose. Steroids act very fast. So in a patient with acute VKH, steroids will act very fast to control the inflammation. But for long term, you cannot use large doses of steroids for a long period because it is very toxic medication. Steroids are the most toxic drugs that you can use to treat a patient with. So in the acute stage of non-infectious uveitis, can be controlled with large dose or high dose systemic corticosteroids. But you need to taper this to safe level. And frequently when you taper to safe level, which is 10 milligram or less, flare-up will develop. That's why we are always use steroid-sparing agents. We are always use combined nowadays. In the past, people were treating only with systemic corticosteroids. We combine systemic corticosteroids with an immunomodulatory agent, such as, for example, antimetabolites or anti-T-cell medication to act as a steroid-sparing agent. Again, long-term treatment with systemic corticosteroids is associated with unacceptable systemic and ocular side effects. We should not use this. If any one of you come to our uveitis clinics, you will never see a child with cushionic face. You will never. Because we are always using steroid-sparing agent. So if we look at the pattern of uveitis in our region, comparing it to other geographic regions, we'll see a big difference. In other geographic regions, anterior uveitis is the most common, 55%. In our region, pan-uveitis is the most common. Why is that? Because in our region, the most common uveitic entities are VKH, followed by tuberculosis, followed by Behçet, and the three most common uveitic entities in our region are pan-uveitis. That's why in our region we have more difficult uveitis to treat. So in our region, pan-uveitis is the most common, followed by anterior uveitis, posterior uveitis, and intermediate uveitis. In other geographic regions, anterior uveitis is the most common, followed by posterior uveitis, pan-uveitis, and intermediate uveitis. Now, corticosteroids, their way of action is very complex. But we know that there's an important inflammatory signaling pathway called the nuclear factor kappa P. This nuclear factor kappa P signaling pathway control all pathways related to inflammation. And corticosteroids, they suppress nuclear factor kappa P. That means that corticosteroids, they suppress all inflammatory pathways. And that's why they are very effective in high doses. They inhibit phospholipase A2 production, inhibiting production of arachidonic acid and its metabolites, prostaglandin and leukotrienes. شكرا. بس هو بيظهر هنا؟ لا. طب لازمته ايه؟ شاشة. بس تقدر تتحرك. شكرا. لا. So corticosteroids can be given topical. All of us are familiar with Pred 40, periocular, subtenon, subconj, intravitreal, and systemic. The starting oral dose of corticosteroids is 1 milligram per kg body weight of prednisone. But in severe cases like in Vogt-Honig-Harada disease, at initial presentation, we give the patient pulses of IV methylprednisolone over 30 minutes or more. We used to give 3 doses, but nowadays we give 5 doses for pulse steroid therapy. This is for immediate control of the inflammation. Side effects of steroids are many. As I said, these are the most toxic drug you can treat a patient with. And I don't feel comfortable to see a child coming with cushingoid face, with even diabetes, obesity. And so I feel guilty if we give children, especially, such high dose of steroids for a long time. So cushingoid changes when prednisone is given at a dose more than the physiologic dose of 5 to 10 milligrams per day. Adrenal suppression, growth retardation for children, osteoporosis, diabetes, hypertension, fluid retention, hypokalemia, hyperlipidemia, glaucoma, and cataract for topical treatment, infection, anxiety, lack of sleep, mood changes, even suicide tendency can be induced by systemic corticosteroids. So in order, if you give patients steroids, you need to monitor blood pressure, blood glucose, serum electrolytes every 3 months, bone mineral density evaluation, blood cholesterol, and lipids annually. In our clinic, we all the patients who are receiving immunosuppressive therapy have regular follow-up with a medical doctor. And we have a protocol for evaluation of these patients based on this lecture. Patients are given supplementary calcium, vitamin D, replacement, and if anti-resorptive agents such as calcitonin, if bone mineral density studies show osteoporosis. We can give steroids also intravitreal. So the first intravitreal steroid that was available to us was triamcinolone. It's not used as frequent as before. It was used as a dose of 4 milligram and 0.1 ml. We used to give it in patients with resistant macular edema despite whiteness of the eye. Complications, of course, are cataract and glaucoma. Then this was followed by the availability of implant, intravitreal implant called Retisert, which contained fluocinolone acetonide sustained drug delivery intravitreal implant. The disadvantage of this implant is that to insert it, you need surgery to make an incision in the sclera, and to remove it, you need another surgery. And frequently there are complications. So the complications are 93% of these patients, they developed cataract, and 37% require surgery to control intraocular pressure within 3 years. The complications that are related to the surgery to insert and their presence into the eye is hypotony, implant malfunction, retinal detachment, endophthalmitis, it's surgery, scleral thinning, opportunistic infection. That's why this implant or Retisert did not receive a lot of interest. There are few reports that came that showed efficacy, but also complications, and it is not used regularly. But what is now becoming more popular, and we have it in our clinic, but also not for all patients, Iluvin. Iluvin is a fluocinolone acetonide intravitreal implant. You inject it through a 20 gauge needle. It releases the steroid over 3 years. So one injection one injection will be effective for 3 years. We have a good number of patients that we treated with Elovent. Also, I'm talking about selected cases that had severe cystoid macular edema, uveitic macular edema, that despite that the inflammation is completely controlled, Elovent was the drug of choice, because you control the inflammation, you control the edema for 3 years. The disadvantage that it is expensive. As far as the first patch that we bought, each one cost about 42,000 riyals. And but if you look at the cost, if this patient need Ozurdex every 3 months, at the end the cost will be the same. So one injection that gives, and our experience is that the risk of glaucoma is not high. So I think Elovent is a drug which is very important to treat uveitic macular edema, which is resistant to systemic immunosuppressive treatment. We have also dexamethasone intravitreal implants, releasing dexamethasone. However, at the beginning, the company told us it works for 6 months, which is not correct. Maximum period of action is 2 to 3 months. So this again, the patient need repeated injections. If you want to give the patient one injection that will last for 3 years, it's Elovent. Antimetabolites are used very frequently in uveitis, Imuran, methotrexate, mycophenolate mofetil. Now, in the past, we were using azathioprine a lot, but since we ordered mycophenolate mofetil, this is the drug which are using most common because of less side effects. It's more expensive, but less side effects. Methotrexate, it is used mainly in the children. It's given once a week, and the children tolerate it. So azathioprine, it interferes with purine synthesis, blocking DNA and RNA replication and transcription. The starting dose is given only 1 to 3 milligram per kg per day. Each tablet contains 50 milligram. The rheumatologists, they like to use it in patients with special disease. We always believe that, or feel that, mycophenolate mofetil is not only more effective, but also less side effects. All antimetabolites, they have 2 major side effects. They can suppress bone marrow, reversible bone marrow suppression, and they can affect liver functions. So therefore, these patients, they need to be followed up by CBC, platelet count, liver function studies. Methotrexate is a folic acid antagonist. Methotrexate is a folic acid antagonist that inhibits DNA replication and RNA transcription, inhibiting proliferation of rapidly dividing immune cells. It can be given orally or subcutaneous injection. We tried oral treatment. Each tablet contains 2.5 milligram. However, many children, they cannot tolerate it. They vomit it. So therefore, we can shift them to subcutaneous injection, and the dose is ranging between 7.5 to 25 milligram once a week. And this is, of course, you should give the patient supplement of folic acid. Mycophenolate mofetil, it inhibits proliferation of T and B cells by inhibiting inosine monophosphate dehydrogenase involved in the de novo purine synthesis. It's given orally 1 gram twice a day. But in some patients, we can increase the dose up to 3 grams per day. Again, it can affect liver enzymes, so we have to monitor liver function, and it can inhibit bone marrow function. T-cell inhibitors, the T-cell inhibitors that we are using, cyclosporin and tacrolimus, they act by interfering with interleukin-2 signaling. Interleukin-2 is an important cytokine that involved in the proliferation of T cells. So if you inhibit interleukin-2, you inhibit proliferation of T lymphocytes. The major side, in the past we were using cyclosporin a lot, especially in patients with Behçet, and this is before the availability of biologics. But nowadays, it is not used as frequent as before. The starting dose usually was 5 milligram per kg body weight. In fact, when cyclosporin was used initially, it was used as a dose of 7 to 10 milligram per kg. But all these patients developed nephrotoxicity. Therefore, nowadays, the starting dose is ranging between 2 to 5 milligram per kg per day, divided into 2 doses. The side effects are many. The worst is nephrotoxicity, hypertension, hepatotoxicity, gingival hyperplasia, increased body hair. Some Japanese, our Japanese colleague believes that it induces central nervous system complications. Therefore, you need to monitor the patient with blood pressure and serum creatinine. Tacrolimus is a drug which is related to that of cyclosporin, and you cannot give both cyclosporin and tacrolimus because they act by inhibiting interleukin-2 signaling. Alkylating agents, I'm just adding it to tell you that we don't use it anymore. We don't use cyclophosphamide or chlorambucil with the availability of biologics. So how about biologic agents? In my opinion and opinion of all uveitis specialists, that biologic agents was a revolution in the management of uveitis patients. So these drugs is based on our understanding of the immune response. We shall discuss this now. That not people, some people believe that a single biologic can treat all types of uveitis, and this is not correct. I'm going to show you examples. So biologics, you have to understand the immune response of each of this uveitic entity to give the patient the right biologic. We know that autoimmune uveitis include a wide range of inflammatory diseases, and each one of these should have its immune response. If you look, this is the phenotype of what? This is a clinical phenotype of HLB27 uveitis. You can see clearly the fibrinous reaction. So HLB27 uveitis is associated with its specific clinical phenotype, which is fibrinous reaction in the anterior chamber. Behçet with hypopyon, severe vitritis and retinitis. So the clinical phenotype of Behçet is different from that from HLB27. VKH, exudative retinal detachment, optic nerve granulomatous choroiditis, totally different from that of Behçet and HLB27. Chronic recurrent VKH, granulomatous inflammation of the anterior segment with sunset glow fundus. Sarcoidosis with such large matum fat KPs. So based on our observation over the years, I was believing that each of this uveitic entity should have its own cytokines and chemokines that drive the inflammation. That means that not all biologics, because each biologic will target one pathway or one cytokine or one chemokine or one receptor, should not be effective in all uveitic entities. That's why we started a big study that resulted in about 8 publications to understand the immune response in each of these uveitic entities. So we know that cytokines and chemokines control inflammation and have important roles in the pathology of various endogenous uveitis entities, thus representing major targets for clinical intervention. Therefore, we believe that characterization of the cytokines and chemokines in the aqueous humor from patients with active uveitic entities is important to understand the immune response in each of these uveitic entities. That's why our studies was based on analyzing the aqueous humor samples from patients with specific uveitic entities using multiplex assay to allow us, we looked at about 60 inflammatory biomarkers that allowed us to look at the difference between each of these uveitic entities. So our studies, we showed, for example, that interleukin-1 beta, interleukin-1 beta is an important pro-inflammatory cytokine, was not existing in the aqueous humor. So if it is not existing, do you expect it to be a good target for treatment? No. So there was a company called Zuma from the States, and they developed a drug called gefacizumab, which targets interleukin-1 beta. And this, the drug was produced by a French company called Servier. So they started a multi-center study to test the efficacy of anti-interleukin-1 beta in patients with Behçet disease. They communicated with us, and then we told them, in addition also to my colleagues in Leuven with whom we are collaborating, that we never detected interleukin-1 beta in the aqueous humor from patients with uveitis. So we don't believe that your drug will be effective. But they insisted, and there was a big multi-center study. And at the end, Zuma gefacizumab fails phase 3 trials in Behçet disease. And that was a very important lesson for us, that what we are doing internationally is very important, is that we tell the scientists, the companies, that we have to look first in the eye of patients with uveitis to find out which biologic should be the most effective. Then if we look at biologic agents used in uveitis, we have interferon alpha 2A, we have tumor necrosis factor alpha inhibitors that should work in patients who have high levels of tumor necrosis factor alpha. Infliximab is the most famous, etanercept, adalimumab, and golimumab. Etanercept is not used in uveitis. Etanercept is a soluble tumor necrosis factor receptor. It's a soluble receptor. Many studies show that it is not effective in uveitis, but even it can induce new uveitis. So it is ineffective, and it can produce worsening of uveitis and de novo induction of uveitis. So we don't use etanercept in uveitis. It is used by rheumatologists for Crohn's disease and the other condition, but it is not used in uveitis. So the drugs that are used in uveitis are infliximab, which is a chimeric anti-TNF alpha monoclonal antibody. What does it mean, chimeric? Chimeric means part of the molecule is of mouse origin. Therefore, patients, we have to be very careful, because the patient can develop severe anaphylactic reaction during the injection of infliximab. Patient can receive 10 infusions, but in the 11th infusion develop anaphylactic reaction. And also the patient can develop antibodies against the molecule itself. That's why infliximab need to be combined with anti-metabolite such as methotrexate, like they do in rheumatology, to reduce the risk of having antibodies. Adalimumab or Humira is completely humanized. It is given subcutaneous every other week. Golimumab, it's more or less the same as Humira, which is fully humanized antibody. If we look at IL-1 inhibitors, I just discussed shivakizumab. There is anakinra and canakinumab. These are not used for uveitis. It might be used for other purposes, but we know that IL-1 is not a major driver. Now, when it comes to tocilizumab, it's available. It blocks interleukin-6. Interleukin-6 is an important pro-inflammatory cytokine. It acts by binding to transmembrane receptors, interleukin-6 receptor. Tocilizumab is blocking interleukin-6 receptor. So it's blocking interleukin-6 receptor pathway. We know that this pathway is important in HLB27 and Behçet. I shall come to this later. So tocilizumab can be used for this purpose. Rituximab, we use it very frequently. It's a chimeric monoclonal antibody directed against CD20 antigen. You know, CD20 antigen is a marker on the surface of B lymphocytes. So that means that rituximab should be effective in autoimmune diseases controlled by B lymphocytes. مش كده؟ This is a table, but now looking at important cytokines. Tumor necrosis factor alpha. Tumor necrosis factor alpha is a major pro-inflammatory cytokine. It induces other cytokines, other chemokines, adhesion molecules. It's very important pro-inflammatory cytokines. So, of course, if for our sake of our study, we should have looked at tumor necrosis factor alpha. It's a major pro-inflammatory cytokine. And our studies showed that it is upregulated in patients compared to controls. But then when we dissected its role in different uveitic entities, you will see that it is highest in patients with Behçet disease and HLA-B27, and very low in sarcoidosis and VKH. That's why I never use anti-TNF alpha agents in VKH. We know that it doesn't work. But we use it in Behçet disease. And again, the high level in Behçet and HLA-B27, and we know that in patients with ankylosing spondylitis, frequently are treated with Humira, adalimumab. And this is based on the fact that in these two inflammatory conditions, Behçet and HLA-B27, the levels are عبد الله انا اكلمك بعد المحاضره عبد الله. In patient with Behçet HLA-B27, they have the high levels of tumor necrosis factor alpha, which is blocked by infliximab and adalimumab. So these two conditions, anti-TNF alpha agents should be effective, but not in VKH or sarcoidosis. Or perhaps the efficacy will be much less. So infliximab, as I said, is a mouse human chimeric immunoglobulin G1 monoclonal antibody to TNF alpha. It neutralizes both soluble and membrane-bound TNF alpha and inhibits a broad range of biologic activity of tumor necrosis factor alpha. They give an intravenous infusion, 5 milligram per kg. In children, you can give up to 8 milligram per kg over 2 hours at week 0 to 6, and then every 6 to 8 weeks. Side effects. You have to be very careful because it can induce tuberculosis. So before we start infliximab or anti-TNF alpha agents, we look carefully at the tuberculin skin test. If the patient is positive, then the patient should be covered with anti-TB treatment, prophylactic like INH. And then it can cause also demyelinating disease. So we have to be careful. Other complications are not very dangerous, but tuberculosis is the most dangerous complication. So please, before you start anti-TNF alpha agents, make sure that the patient does not have latent tuberculosis. Is this clear? We published before about the efficacy, and we showed that and we are collecting also new data to show that infliximab or anti-TNF-alpha agents are very effective. It allowed us to save the vision of many patients with Behçet uveitis. Humira or adalimumab is anti-TNF-alpha agent, but it is completely humanized. It is given subcutaneously for adults 40 milligram every other week. But for patients with severe inflammation, you can give it on a weekly basis until you control the inflammation. Nowadays, both infliximab and adalimumab are recommended to be used as a first-line treatment in patients with Behçet uveitis, severe Behçet uveitis. That's why, alhamdulillah, in our clinic, we have, by the way, just one clinic in Thursday afternoon for patients receiving infliximab or biologics. So we are now able to save the vision of any patient with Behçet uveitis because we have very effective medication. We should use it as a first-line treatment. Examples. So these are very aggressive cases of Behçet uveitis. You can see severe vitritis. You can hardly see the optic nerve, and you can see the large patches of retinitis. These patches of retinitis are very important sign of severe inflammation. It can be the first sign of a flare-up in a patient with Behçet disease. And you can see the diffuse leakage on fluorescein. And after treatment, we are still seeing this patient with vision 20/20, 20/30. No optic atrophy, no white sclerosis visit, because we use the infliximab as a first-line treatment. Another patient with, as you can see here, the retinitis can develop in the fovea, like in this patient. And this is a typical fluorescein angiography, vascular lesion, leakage involving the capillaries. And then after infliximab. So I have so many examples, and of course, macular edema responds very quickly to infliximab. There's one patient, Abir, you admitted, the one-eyed patient, and after the phase of infliximab, macular edema was completely controlled because infliximab also will control macular edema in patients with Behçet disease. So this is a patient with central retinal vein occlusion, inflammatory. Why it is inflammatory? Because you can see vascular sheathing. And this is infliximab. Believe me, he has 20/20 vision. Again, another inflammatory branch retinal vein occlusion in patient with Behçet disease. What are the other signs of branch retinal vein occlusion in this patient? ممتاز. Where are the collaterals? Collaterals temporal to the macula, because today I was giving CTR, I was showing collaterals on the disc because of CRVO. But collateral temporal to the macula are suggestive for recurrent branch retinal vein occlusion. So another patient before and after infliximab. So as you can see, patients, they present with a very aggressive vitritis, retinitis, vasculitis, but infliximab helps us to control the inflammation. Now, IL-6, interleukin-6, is a multipotent pro-inflammatory cytokine regulating both B and T cell activation and differentiation. And we have shown, if you look here at, this is from our data, the highest levels of IL-6 are in HLB27 and Behçet, but low levels in PKH and sarcoidosis, which means that the IL-6 receptor axis will be very important for HLB27 and Behçet. If you want to use rituximab, tocilizumab, so it should be for HLB27 and Behçet disease. So IL-6, interleukin-6 receptor axis might be a target pathway for the treatment of HLB27, uveitis, and Behçet disease. And this is in agreement with clinical trials. How about lymphoid chemokines? Lymphoid chemokines are chemokines that act on B cells. And just to make it short, one of these lymphoid chemokines called CXCL13. It is called B cell chemoattractant. So it is a chemoattractant and activating chemokine for B lymphocytes. And many studies showed, you know that B lymphocytes now are considered to be important in the pathogenesis of many autoimmune diseases, even autoimmune diseases that was thought to be mediated by T cells. Therefore, B cells are involved in multiple sclerosis, rheumatoid arthritis, SLE, so many autoimmune diseases. If CXCL13 is, we showed in 2 studies that it is a biomarker mainly for VKH. The yellow is VKH. These are the representatives. Look at this. Compared to sarcoidosis, compared to HLV27, and compared to Behçet, and this is control. This is one of the studies that I am very much happy that we published to the international community to know that VKH is driven by B cells. So our findings suggest that CXCL13 is a biomarker for VKH disease, and that B cells are important in the pathogenesis of resistant VKH. Therefore, based on this, treatment with rituximab, antibody against CD20, leading to depletion, because how does rituximab act? It acts by depleting B lymphocytes, might be effective in patients with VKH disease. We also, from one of our previous studies, sympathetic ophthalmia, you know, of course, that the pathology of sympathetic ophthalmia is very similar to that of VKH. مش كده؟ These are eyes inoculated years ago because of sympathetic ophthalmia, and they were preserved in the Department of Ophthalmology at Ghent University. So we collaborated with them, and we examined these eyes to understand better the immune response in the choroid of this patient. And then you can see here this is a marker for T lymphocytes. So the red cells are the T lymphocytes, and this is a marker for B lymphocytes. So the red cells are B lymphocytes. Which cells are more? B lymphocytes. And that was this paper published almost 10 years ago. So now, based on this, we are now believing that this VKH is driven mainly by B cells. So this finding suggests that treatment with rituximab and antibody against CD20 might be effective. That's why we were the first group to publish about rituximab. Based on our data, we had to take permission of using rituximab for patients with resistant VKH. And of course, we have to provide the committee with proof for this, our publications. And then they allowed us to use it for, I remember at that time, 6 patients per year. And this is a patient. Look at this. This is chronic recurrent VKH. The patient was depressed because of many courses of immunosuppressive treatment that failed. This patient was not treated in the acute uveitic phase during the window of opportunity properly. She was left to progress into chronic recurrent VKH with synechia, with granular inflammation. And then this was one of the first patients that we gave her rituximab. And then you can see after rituximab, we were able to control the inflammation with rituximab and also to taper the other immunosuppressive treatment. So what is this? Huh? Yak BI. Why? Because she had many attacks of pupillary block glaucoma because of cyanikin. So this is, and then quietening the eye allowed us to do hair cataract surgery. So we did hair cataract surgery, but you can see, of course, the sun-signal fundus. This is another patient, again, with, in another hospital, the patient lost her right eye. They did hair cataract surgery without good control of the inflammation. And after rituximab, we control the inflammation in her left eye. This is another patient. You can see the matum fat KPs. You can see the iris nodules. And of course, this will happen with sun-signal fundus. And after rituximab, we were able to control the inflammation. So rituximab, so what I want to say here is that basic science research will help to improve the treatment of patients. You agree with me? If we understand the immune response in each of these uveitic entities, we shall give the patients the proper treatment. Interferon alpha 2A, we tried to have it available in our hospital, but I don't understand why the company is not producing anymore. Because interferon alpha, the interest for interferon alpha 2A came after the studies by our friend, the late Professor Manfred Zerut from Germany, because he is the one who started the work of using interferon alpha 2A in patients with Behçet. Of course, in Germany, you know, there are many Turkish people living in Germany. And of course, all his studies were on this Turkish patient in Germany who had severe Behçet uveitis. And he was the first one to show that interferon alpha 2A was very effective in Behçet uveitis in these patients. As you know that Behçet uveitis is more aggressive in Turkish population compared to our population. So he shows that it is effective in ocular Behçet disease, leading to significant improvement of vision and the complete remission in the majority of patients. His protocol at that time was using 6 million units subcutaneous daily for at least 14 days, tapering to 3 million units per day every other day, and continue maintenance for 6 months and then discontinue. And he found that good number of these patients, after he stopped the treatment, they remained quiet. 40% were disease-free of all medication at 3 years, while others were maintained at 3 million units 3 times weekly. The side effects of the drug is mainly flu-like symptoms. I remember during the discussion with him, he told me that if the patient develops flu-like symptoms, he knows that the drug will be effective. It's a sign that the drug is effective. If the patient develops flu-like symptoms. Other complications are reported, like leukopenia, alopecia, depression, autoantibodies, Hashimoto's thyroiditis, but these are not common and can be reversed by discontinuation of the treatment. So the approach to treatment of patients with uveitis is nowadays very simple. You have to rule out masquerades. Malignancy can masquerade as uveitis, and also to rule out infection. It doesn't matter if you delay the treatment few days that are needed to rule out infection before you start immunosuppressive therapy. Don't rush. Today I was giving in the CTR a patient with very active toxoretinitis that the day that the patient came to see me in the clinic, he was scheduled to receive intravenous methylprednisolone in a big hospital. But the patient, when he came to me in the afternoon, he said, I was not sure that this drug will be good for me, So I left the hospital and came to our hospital. And the patient has toxo. Would you give steroids to a patient with toxo? So you have to be very careful. So take your time to rule out infection. But also, you have to know that, like in patient with VKH, you need early and aggressive anti-inflammatory therapy to suppress the inflammation maximally. Patient with VKH, if the patient misses the window of opportunity, the time at which the drug will be most effective in the early phases of the disease, the patient will progress into chronic recurrent evolution with all the complications. So this does not mean that you need to start the treatment immediately, but you need 48 hours to make sure that you are ruling out infection. Steroids are important at high doses, especially in patients with VKH, to control the inflammation rapidly, but not for long-term treatment. Large dose, high dose steroids for a short period, and to continue the control with steroid-sparing agents such as mycophenolate mofetil. Why mycophenolate mofetil cannot be used to control the inflammation immediately? Why? It takes time to act. It needs 8 weeks to act. During this period, keep the patient on a large dose of systemic corticosteroids. The initial treatment to control the inflammation, we can give steroids IV methylprednisone pulse or oral 1 milligram per kg body weight. And then we taper the treatment after control of the inflammation and to continue with immunomodulatory agents. We don't use any more cyclophosphamide and chlorambucil. Biologics are used, as I said, as a primary treatment in patients with partial uveitis involving the posterior segment. In the children, the main drug that we use for children, we don't give steroids at a high dose for a long time. We give it for a short period to control the inflammation, but we'll continue the control with our first line of treatment is methotrexate. But there are practical issues that these children, they will need influenza vaccine. They will need varicella zoster virus immunoglobulin upon close exposure to patient with chicken pox. You should not give these children live virus vaccine while on therapy and for 3 months after stopping the treatment. In children, there's also problem with compliance. Pregnancy. The 2 safest drugs for pregnancy are steroids and cyclosporin. Thank you very much. I am seeing صديق عزيز أخ عزيز الدكتور أحمد موسى. ما كنتش عارف إنك جيت. الله يحفظك. فالحمد لله على السلامة. لا. Any question?